Those of you who don't know me, I'm Dr. Connie Arnold. I'm a professor of medicine and a medical sociologist. And so that's my research funding. I always disclose it. The goal for today is to discuss with y'all the problems with informed consent, provide you with examples of how to improve it, and also to talk about what's just equally as important than informed consent is the consent process. And so a question to start off with is, how good do you think you are at explaining things to your patients? This is probably me at the doctor's office. I'm going to take your blood pressure, so try to relax and not think of what high reading might mean for your chances of living a long and healthy life. And Einstein said, if you can't explain it simply, you don't understand it well enough. And what I would agree with is, and what I would argue with that point is, for all of y'all, you've been in med school, and you've talked and you've discussed things on a certain level. And now you have to switch gears when you see patients. And that is a learned process. And it's something that you learn as you go along. It's not quite as easy. So why is consent such a hot topic? Well, clinical research is growing. There are 2.3 million participants a year that sign consent forms. Consenting patients takes an increasing amount of time and preparation and training. The issues also are more complicated. The studies are more complicated. They're more likely to include multiple sites, large number of participants, data sharing, biospecimen, confidentiality concerns. You know, in the consent form, you always have to say, we can't guarantee your confidentiality. We could do everything to protect it, but, you know, anybody who listens to the news knows that everything gets hacked. There are very few things that aren't hacked, so our patients aren't as trusting. And so the idea is that with consent, what we want to do is be transparent, because in the cases when we haven't been transparent, this is why patients don't trust us. This is why patients don't want to enroll in studies. It usually isn't from a fear of the study itself. It's from the lack of what they know and what they trust you're telling them. We know there's growing regulatory scrutiny. Funding agencies are concerned that patient comprehension of the basic concepts and requirements is poor. And that's a very valid point. So why focus on health literacy? Nearly 9 of 10 adults have difficulty using health information that's routinely available in healthcare facilities. Researchers and clinicians often fail to grasp the gap between what they want to communicate to their patients and what their patients actually understand. Nationally, health research, delivery, technology, and insurance costs are changing rapidly and bringing new communication challenges. And so DHHS's National Health Literacy Action Plan calls for information to be accurate, it has to be accessible, it has to be understandable, and patients have to be able to act on it. And most consent documents, being transparent, I sit on the IRB. And so I am considered the health literacy expert. So I get to look at especially the new studies, I get to look at all the consent forms. And I would say that most consent documents are not designed to truly inform patients about research procedure. And I'll talk to you in a few minutes about how to change that and some of the pitfalls that people make. And researchers may assume when you're embedded in a research project, you know the ins and outs of it. And sometimes we forget what patients don't understand. And so health literacy is essential in improving research because it impacts patients' understanding and outcomes. 1 in 3 adults in Louisiana have low health literacy. Rates are double for low-income minorities and the elderly. That's the population we serve. That's the patients you see. Low health literacy is linked to poor health knowledge, self-management of chronic disease. It's linked to poor medication adherence and preventive care. So many of y'all may have seen this. For those of you who haven't, I'm just going to go really quickly through a couple of slides that tells you about the problem. When we think of literacy, literacy is just not about reading. You have to be able, it involves reading, you have to write, communicate. It involves math skills, which are worse than literacy skills, problem solving, judgment, and now we have the internet skills. And so the National Adult Literacy looked at, it was a household survey of functional health literacy skills of 26,000 adults. If it has since been updated, but it was done in 1998. We always laugh and we say, thank God for Mississippi. They're usually worse than Louisiana. Mississippi, their whole state, greater than 30% have patients on the lowest literacy level, over a third of their population. But we're not much better. So this is us by parishes. If you notice, if you look at the Delta region, it falls in the same. We have no purple parishes. This is us in Caddo. Bossier has a little bit higher literacy, and we don't have very many green. So 28% of Louisiana adults are on level 1. If you look at New Orleans, that's 39%. The communication with patients who speak a language other than English is also problematic. 18% in the U.S. speak a language other than English at home. There are 145 languages spoken at home in Houston. 54 million Latinos in the U.S., 18 million do not speak English well. Their health literacy is low among this group with limited English. A UC San Francisco study found that 63% of LEP patients understand instructions from a provider who is language concordant. So 63% understand if they speak the same language as them. Only 35% understood instructions from an interpreter. And what do we use here? Usually it's a family member, it's an interpreter if we can't get it. Terry Davis, who's a colleague of mine, says more and more fourth-year medical students are talking about they're seeing a lot more Hispanic population here. So we have an Hispanic population who may not necessarily speak English. So the NIH view of health communication is not to blame the individual. When we started out with health literacy, it was an individual problem. Now it's about how can we help patients understand. Everyone, no matter how educated, is at risk for misunderstanding health information, especially if it's emotionally charged or it's complex. If you're told you have cancer, if your child is really sick, there may be a lot of complex procedures. There's a lot of emotion tied into that. I'm a parent of 2. I have a 26 and 20-year-old. But I can tell you when I used to take them to the pediatrician, when they were sick, I would come out of there, and I probably did retain about half of what my pediatrician told me because I was upset, my child was upset, and so there are a lot of things that go into it. In almost all cases, scientists and physicians believe they are communicating understandable information. The worst thing that you can ask a patient is, did you understand what I say? Because patients with low literacy are going to tell you yes. They're not going to tell you they don't know, because that is something they want to keep hidden. I can sit in grand rounds, and as a medical sociologist, I was a math major before I was a medical sociologist. I can tell you there are a lot of grand rounds I don't understand. But I'm not going to be the first one to go up there and go, I didn't understand a word you were saying. So, you understand why people don't, how many times have you said you understood something just because you didn't want to look like, you felt like an idiot and you didn't want to say anything? Also, it's increasingly difficult for people to separate evidence-based information online and TV from misleading ads and gimmicks. How many ads do you see on TV from the Cancer Center of America? And you have to read the really fine print, like on the drugs they're advertising for lung cancer or anything, to understand that the increase may be in months of the improvement. And patients don't see that. They're grasping for the hopeful end of it. So red flags for limited literacy. What are some red flags? Sometimes patients have what nurses have often said, they have a vacant look. They just kind of have this blank look. They may say, I forgot my glasses, so they don't have to read something. They ask fewer questions or no questions. They have incomplete forms. They have frequently missed appointments because they can't They don't keep up with things on a calendar. They can't read their appointment card. On level 1 means you can't read your appointment card. That was the task to be able to assess a level 1 low literacy. Is they were given an appointment card and you had to say what time your appointment was. They can't give a coherent sequential history. They're not taking their medications correctly, and they lack a follow-through with referrals. So the single biggest problem, this is for those of you this is Alan Alda, if you're too young to know who he is. But he now has a book out about communicating and works about communication with providers. The single biggest problem with communication is the illusion that it has taken place. That's what George Bernard Shaw said. And what Alan Alda said was, communication does not take place because we tell somebody something. We think it does, but it doesn't. It takes place when we observe patients closely and get signals that we're on the right track. And also when we have started at a place that they are familiar with and track their ability to follow us. Yogi Berra once said, you can observe a lot just by looking. So this is a great cartoon. When we talk about things that we're doing differently now, when we talk about biobanking and genomics, these are 2 little girls, and this is we always say this is one of our geneticists in New Orleans. When I asked what little girls are made of, I was hoping he was just going to say sugar and spice. So we did focus groups, and we did some with some funding from Weiss-Weiler Cancer Center. And we talked to CRAs and we talked to patients about consenting patients for cancer clinical trials and what their recommendation was. And here are some of the things that and a CRA is a certified research associate, since I can't assume that everybody knows what the initials are. So patients with low literacy commonly say, well, if that's what Dr. X wants me to do, then I'm going to be on it. Especially our cancer patients, they really trust their providers. Patients with low literacy will often ask, if I don't do this, will I still be treated? And they often ask this several times. When consenting a patient that the CRA suspects has low literacy, they will suggest that they take the consent form home to show a family member. And what happens is often an adult daughter will call back, or they'll come back and accompany their parent. Sometimes the daughter doesn't want the parent participating. Highly educated patients will often go home and Google the clinical trial. And a few patients call the cancer center after looking at NIH websites for studies. But that's a rarity here. That's how patients find out. So what do patients have to say about consent? They want forms with large print, plain language, bullets, and pictures. They don't want it read to them. What they want it is discussed with them. And they want one-on-one discussions, and they want it repeated multiple times when they come back. So this was the results about clinical trials and recruitment. We did it in 78 urban and rural community clinic patients with 78% who were African American. People are increasingly aware of clinical trials and personalized medicine due to the ads on TV. They're especially aware of 23andMe and Big Center genomic-based information ads. Most rural and urban participants are open to participating in clinical trials and biobanking, even if it won't directly benefit them. African American participants said, the message needs to be, all people are needed for studies to improve treatment and find cures. One of the problems with personalized medicine is most clinical trials in the past have been on white men. And so for personalized medicine, we need more minorities, and we need more women on studies. But one of the things they didn't want researchers to do was to use the rationale that blacks have been underrepresented because they feel like it targets African Americans and it makes them suspicious. Cancer patients and Alzheimer's caregivers were highly interested in clinical trials, and patients and PCPs indicated that information and recommendation about participation in clinical trials are most effective if it comes from their PCP. That was truly the bottom line. If my primary care provider recommends it, then I'll trust it. Patients often suggested calling it a study. They don't get the term clinical trial. Biobanking and genomics sounds intimidating and alarming. These terms didn't mean anything to any of our participants. The wording they suggested was your blood or tissue is going to be stored in a bank. Rural patients wanted to know where that bank was located. Why do you want to take blood? What are you going to do with it? How much information about me are you going to keep? What is going to be used? And with genomics, they just didn't want you to get in the weeds. And yesterday on the IRB, we were having, I reviewed a consent form for one of the first ones that was straight up just for personalized medicine and was interested in taking tissue. And so what we had a discussion was, the whole discussion around the country is about transparency about what you're going to do with blood or tissue you biobank. And so what we discussed was having some standardized language that patients would say, yes, you can keep my blood or tissue for this study, yes or no. Then have a separate line that said, you can also keep the tissue or blood after this study for other research. Because there's no way that any researcher can tell you in 10 years what research may be done on that tissue or that blood. I mean, if you think where we were 10 years back and where we are now, there's no way to guarantee a patient that you know what's going to be done with this unless you say, we're using it for this study and that's it. And patients should be allowed to say that. The whole part of transparency and trust is they are more likely to commit to doing something when they feel like you have been open and honest with them. So biobanking communication, will you consider donating a sample of your tissue or blood for medical research? How is donating samples helpful? Why am I being asked to donate? Will it help me to donate my sample? Can I say no to it? Will my decision affect my medical care? These are some of the questions that they had. How will my information be protected? So the challenges in writing consent forms is both on the IRB and the patient side. You always have to understand what the IRB wants. There's a template online that has the basic outline for it. They try and give suggestions. One of the, what can be simplified, you have to remember when you're writing a consent form, what is your key message? And I always allow plenty of time to discuss it with patients and realize if there are distractions or what there is. So Winston Churchill once said, this paper by its very length defends itself against being read. This is part of a consent form. Now this is probably a couple of years back. I will say consent forms have gotten better. But this was one page of 20 pages. I can tell you that the majority of the patients that we see, that would stop them right there. That would probably stop me. If I wasn't forced to read it, I would stop right there. So you want to develop content from the patient's perspective. Use a conversational tone, get to the point. Don't get in the weeds. You know, I think one of the things that I've always had an issue is we always start our consent forms with what is consent? And there's a whole paragraph on what is consent. You know what the patient wants to know? Why are you asking me to be in this study? What are you going to do to me? I don't think we need a whole paragraph on consent. Consent just means you're going to give your approval, and you don't have to do it. You're going to give your okay. This is just a checklist. Is it written in plain language? Are you using consistent terms throughout the form? Is it written in an active rather than a passive voice, your signature versus the signature of your patient? Is it formatted for reading ease? Is it too long? What is the plan for discussing the information with the patient? Does the form and consent discussion help the patient? The whole goal is to help the patient make a decision about participating in the study. And of course, will the IRB approve it? Usually, I have to tell you that the only times that you run into a problem with a simplified form, the IRB not approving it, is when you leave out information, say on risk that's in the protocol. One of the things that they do, if you're doing research here, is you're looking at what you're going to say, what you say you're going to do in the protocol, and does it match with what you say you're going to do in the consent? Consider the reading level. Like I said before, the average education level of U.S. adults It's supposed to be less than or equal to. This is then a 12th grade level. The average education is greater than a 12th grade level. The average reading level is about an 8th grade level. So we say aim the materials for around an 8th grade. There's nothing magical about it. Some forms, I can't even get that low. It just depends on how we do it, but it's just the tip of the iceberg. So there is a very simple way to do reading level if you have Microsoft Word. The thing you want to remember is reading formulas are imprecise measures. Reading grade level of material does not correspond with the patient's ability to read and understand. It's just a marker. It's just a tool we use. And I always say, no, this is not how Terry and I do this. Although I do think people think that's how we do it. So reading level. If you have Microsoft Word, there is a tool in there you could go in and do the Flesch Kincaid tool that gives you a reading level that tells you how to do it. There's a booklet. If anybody wants this information, it's really easy to do, and it takes about 2 seconds to go through spelling. And at the end, it will give you this box that says all these things about what the average sentence was, what your reading level is, and those kind of things. So we have in one of our guides that we have that I'll show you at the very end is a plain language Thesaurus. So these are a lot of words that patients don't understand. Adverse events. It's just a bad reaction. You know, we have on one of the videos we have one of our patients and they're reading, it was an insurance form and it was a consent form actually, and it says I authorize. And so Terry asked the patient, what does authorize mean? And she goes, I have no idea. So I mean, that's pretty key when you're trying to get someone, when you're discussing a consent, whether it's a procedure or it's a clinical trial, that they don't understand, and they're not going to tell you I don't understand that. So it means to give your okay in writing. Clinical trial, as we said before, just call it a study. You can call it a research study. Disclosure, especially multiple syllable words, a lot of times what patients don't understand. The information that you give to us. So as I said before, use active voice, break text into what we call manageable chunks. We call it lump and clump. One idea per paragraph. Limit your paragraph to 3 or 4 lines. Aim for less than an 8th grade level. Here's one of the first things I ever do when I'm working with somebody to help them with a consent form or a document or anything they're doing. I'll take a paragraph and I'll just bullet the sentences. And that's how I start off, because then I can see sentence by sentence. Okay, is this necessary? Can I shorten the sentence? It's a little bit overwhelming, even for me when people send me things, to look at full paragraphs. But when you bullet it, you know, that's why patients like it. It gives you breathing space. You can see more. And so white space, bullets, bolding, simple headers, short sentences, that's the goal. And so if you look at this, what you see is the eye has space to, what we call space to breathe. So you don't feel overwhelmed by the page, and you don't feel overwhelmed by the information. This is what we talk about taking chunks and using headers. And so like breaking this up into headers and then putting bullet points under it. And then the one, and that's kind of hard to see, and I apologize for that, but the one we put in the box was we wanted it to stand out because it says, if you are pregnant, you cannot be in this study. That's an important thing that you want to stand out, even amongst the bullets. Okay. This is what happens when I punch things. So I was going to give you a couple of examples. These are straight up from consent forms. You have been selected as a possible participant in this study because you have a moderate to very high risk pulmonary embolism, and it is not if known if retrievable vena cava filters reduce mortality or reduce recurrence of non-fatal pulmonary embolism, or if complications of vena cava filters outweigh the benefits in such patients. That is too long of a sentence. Start out and break it up. You're invited to be in this study because you have had a clot that goes from your legs to your lungs, and then put the word that it is in parentheses, pulmonary embolism. That's the way to start out for this paragraph. I would have another sentence because there's more information in that paragraph, but that's just breaking it up. So this was the purpose of one of the studies that came through. This is a research study. You're being asked to participate in this study because you have COPD. One of the main problems with COPD is that it causes people to be short of breath with exercise. It is also a disorder that causes increased inflammation in the body. The treatments of COPD are relatively limited, and new medications are needed to improve the ability to exercise. Inhaled Ilioprost? You're asking the wrong person. Is it inhaled nebulizer, a medication delivered through a mist into the lungs? Medicine, FDA, the Federal Drug Administration approved for the treatment of pulmonary arterial hypertension, which hypertension, our patients don't understand what that is. So high blood pressure. So, and it goes on, and this is written on 11th grade level. So one of the ways to improve it is to go, this is a research study. You're being asked to take part in it because you have COPD. I doubt very many of our patients call it anything other than COPD. But so the name of it is in parentheses. Treatment for COPD is limited. New medicines are needed to improve patients' ability to breathe better, especially during exercise. This study will test a new medicine, and the medicine's in parentheses, to help you breathe easier. It's a mist which you inhale using an inhaler, which is called a nebulizer. The FDA has said it is okay. They've given its approval to use with patients with high blood pressure in the lungs. It has not said it is okay for use with COPD. The reason it is being tested is it may help you breathe easier. That's on a 6th grade level, and that's the exact same information that was on the paragraph before. So the other thing that we always say is don't forget about numeracy skills. Many patients with adequate literacy do not have great numeracy skills. So they did a study at Vanderbilt, and they said, you drink this whole bottle of soda, how many grams of carbohydrates does it contain? And so 67.5 grams is what it contains. 32% answered it correctly. So you take the number of servings per container and you multiply it times the total carbs. Here is what is interesting. 200 of these were primary care patients, so that 73% had private insurance, which means they had probably a job. 67% had at least some college. 78% read above a 9th grade level, but yet only 37% scored above a 9th grade level in math. That's something you want to remember, because a lot of what we do has to do with measurement. We describe risk. So approximately half of U.S. adults are unable to calculate a tip. If you notice, if you ever go online and order stuff, they calculate the tip for you now on the side. You can just, you don't have to do it for yourself. 20% of college-educated adults don't know which risk is higher, 1%, 5%, or 10%. We know that medication error is the most common medical mistake. There are 1.5 million adverse events with patient error greater than 700,000 persistent errors. 2 out of 3 patients leave their doctor office with a prescription. There are 4 billion retail prescriptions filled in 2014. 82% of adults take at least one medicine. The elderly fill at least 20 prescriptions a year and see at least 8 physicians. And a lot of that, they have to know how many times a day to take their medication, how to dose out their medication. For pediatric, that involves measurement. If it's not a syringe that's marked on it with it. There are over 300,000 over-the-counter medications, and greater than 600 of them contain acetaminophen. So what are some ways to nudge people for better understanding? So provide numeric likelihoods of risk and benefit. Describing risk solely as you have a low chance of experiencing side effects has been proven to be ineffective, because patients vary in what their interpretation of that means. Individuals with lower numeracy skills should be given numbers that are accessible to them. And so provide absolute risk and not relative risk, because relative risk can inappropriately lead patients to believe treatment is more effective, and let me show you what I mean. What if I told you a drug could reduce your risk of breast cancer by 50%? That's a relative risk. What if I told you a drug could reduce your 5-year risk from 4% to 2%? That's an absolute risk. The drug has the same effect, but in the first description, it sounds much better. It sounds like it's a much better choice. 57% of the patients chose the medication whose benefit was in relative terms. 15% chose the medication whose benefit was in absolute terms. And 16% were indifferent when they studied this. The changes in risk appear larger when presented using relative versus absolute. Relative risk can inappropriately lead patients to believe the treatment's more effective than it really is. When I was talking about the lung cancer ad, when you read the fine print that comes on TV, you can see that the length of expansion of life, that's not what's said on the commercial, that this is in a 3-month or a 4-month period. And studies have shown that physicians were more likely to recommend treatment if the information was presented to them using relative risk. Keep the denominators constant if you're talking about several things in a paragraph. Use pictograph or other visual aids. The one thing we found out with our patients when we were doing things, a pictograph with one color, our patients can get. A pictograph, when you suddenly have 2, was a little bit more confusing to them. And they really preferred using a pie graph. They kind of got the image of a pie and they could kind of figure that out. Consider offering things in both the positive and negative. People with less numeracy skills are more influenced when a treatment is described in both positive or negative terms. So try to use both. 60% of men who have surgery to treat prostate cancer will be impotent. This means 40% of men won't. Be careful how you interpret the meaning of important information. Describing information in terms of goodness or badness can affect people's risk perceptions. And I would tell you that developing user-friendly consent form, it's not rocket science, it's just tedious. User-friendly doesn't mean it's dumbed down, and everybody wants simpler information. If you think about it, when people are emailing you or somebody's handing you something or you have to read something, you just want people to get to the point. Just tell me what I need to know and what I need to do. We all want that. We're all busy. And so people often worry, well, are my patients going to be offended, that this is a simpler consent? No. Like if I can read it faster, I often tell people, the discharge instructions I get from my vet are better than the discharge instructions that I've gotten for when my mother's been released from the hospital. On my vet's discharge instructions, here is one line. It says, your dog has been given its medication today. Do not give them their medication. Start tomorrow. Terry Davis will relay her when she had open heart surgery, and she got out of the hospital and she couldn't remember that day whether or not they had given her dose, and she called back and they go, well, you're no longer in our system, and we don't know whether they did or not. Do you remember if the nurse gave it to you? And she was like, I wouldn't be calling back if I knew. So the deal is it just takes time to slow down. So the other thing I want to talk to you about, which is just as equally as important and probably more important, is actually the consent process. This is probably what y'all are more often involved with, is consenting patients, whether it's on procedures, whether it's having them sign the consent form. Patients don't understand unfamiliar medical terms, so some of the research that I wanted to show you, as I said before, patients with low literacy don't ask for clarification. Transcripts of 150 genetic counseling sessions found terms that were jargon, were typically repeated 20 times. I guess if you say it enough times, the patient's going to know what it is, but they didn't know what it was from the first, so repeating it doesn't help. In a study of 800 pediatric visits, only one mother asked for clarification. Many have difficulty understanding and recalling complex information. In a study of 250 orthopedic patients at their first post-op visit, only 45% knew which bone they'd fractured. 19% knew expected healing time, and only 45% knew the weight-bearing status of their injury. In a study of 100 surgery patients, y'all will appreciate this, 95% of surgeons believe their patients understood when to resume normal activities, when in fact only 58% of the patients did. And so, as you may have already seen, patients with low literacy are less likely to actively engage with you and to participate in the dialogue. So the consent process. Always prepare and allow sufficient time, arrange a quiet space, let them include whoever they want to come in there with them, slow down and connect with the patients. Our CRAs will tell you the success they have with consenting patients has to do with the connection they make. That if they can make a connection with that patient and the patient truly gets that they care about them, then the process goes much easier and the patient is much more willing to engage in the conversation. Avoid the formal lecture, walk the patient through the form, discuss it with them, and verify and document comprehension. So this is called strip it down, bring it home, mix it up. Strip it down, limit the unnecessary jargon and complex language, bring it home, make the health information personally relevant. It always helps to begin by asking the patients what they know about whether it's a disease, whether it's a surgery they're going to have, what is their understanding. Because patients bring their own baggage with them. They bring their own preconceived notion with them, their own, what their grandmother told them, what their mother told them, what their friend down the street, well, she had this, she had diabetes, this is what she did. If you can start from what the patient understands, then you have a better understanding of what direction you need to take. And then mix it up, cut the mini lectures and the monologues. We always say have a conversation, explain things like you were going to explain them to your grandmother, explain like you're going to explain them to your aunt or a friend who's not in the medical profession. If you ever have doubt about how you're explaining something, you can come explain it to me because I will be the first one to tell you if I don't understand it. Here, this is an example of a really good group that the pediatric, that they used to practice this consenting process. And so they would practice it and role play with the PI and the team, and they would pair the teams to consent the patient, and then they would go over what they didn't understand. They also like to use a flip chart when they were doing consents. These are parents of pediatric patients, and so it just made it easier for them, and they could use pictures on that. And so like I said, you take a few minutes to connect with your patient, you slow down, you allow enough time, the things we've always said. Here is the one thing, this is very old school, it's the one thing we know that's effective, and that is teach back. Teach back is truly, if you want to know what your patients understood, it's to ask them questions that they have to answer you back. And the way to do that without embarrassing your patient or putting them on the spot is to go, you know what, I do this all day. And I talk to lots of patients, and sometimes I forget some things. So I just want you to tell me back. You can ask them some questions. I want to make sure I've gone over things with you so that you put the impetus on you if they don't remember something. But teach back truly is the most effective way to get at whether your patients understood what you wanted them to. So one of the final things that I'll tell you is from an IRB reviewer, for all of you who have to do research, who have to go through the IRB process. One of the things that I find most often is researchers cut and paste from their grants. You know what? On the protocol, that is fine. IRB members, HRPP has to read the protocol. Your patients don't. But when you get to the consent form, slow down and make it simpler, because what goes in a grant never works in a consent form. It's just too complicated. The other thing that people run into is they write something in the protocol and it's not in the consent. And bullets are your friends. I always tell people that. Bullets are your friends. These kind of bullets that go on the page. Tables are often difficult. I will tell you, people put a lot of things in tables. If you think about the way a table is designed, You have to be able to know rows and columns. Patients with low literacy often can't read a table. You know, it looks simple to us. Some of y'all's tables don't look simple though. But it looks simple, even some of the simple tables. And so I often say, if you want to put a table in, fine, but then put some bullets after it so if patients don't get it from the table. You know, I heard somebody, an expert on consent, talk in New Orleans a couple of weeks ago, and his big thing was, I don't care what the written consent form says, because if you get sued, they're going to throw it out the window. I do care what the written consent form says, because our patients who have low literacy often take that consent form home to somebody to get them to explain it. So I want it to explain. I want it to be the best we can make it. And they definitely have improved. I will say the consent forms that I have seen coming through, whether it's from pharma or whatever, we're doing a better job of. People often say tips on working with IRB and HRPP, realize they want effective forms. I always say it's better to ask before you turn in your stuff. If you don't know how the process works, if you don't ask, you turn it in, they have a question, it gets kicked back to you. You go back in the queue, you answer the question, and it gets kicked back to you. So people often get irritated. The thing to remember, so I mean, it's just my stuff gets kicked back too. So make changes. Any changes you make to your instruments, your protocol always has to be done. You have to do a modification. Know the rules. Stay on top of your paperwork. This is where people usually get in trouble with audits. As the PI, the thing to remember is it doesn't matter who did it. It doesn't matter if one of y'all did it, one of the, if another resident, if a nurse. At the end of the day, you're held responsible for everything that goes on in your study. So I would leave you with some of the, remember the basics. Connect with and engage your patient. Make eye contact. Include family members if appropriate. Engage your patient and build rapport. What will make the patient want to know about the study? What can they relate to? Avoid appearing rushed. I know y'all are rushed. I know how many patients y'all see. Part of it is just fake it. Fake it that you don't look rushed. Because we all know that you see lots of patients. And that's we have this in our office if you're ever working on the study or you're doing on consent forms. We developed it. This is a grant we have with Pennington, LSU New Orleans. We developed it's informed, and it had all this stuff in it, plus a little bit more about how to do your consent forms. The thing I'm going to end with is my story about the consent process and about the process of communications. And so a little while back on a Sunday, I was eating a sausage biscuit, and I realized that when I swallowed it didn't go all the way down. And so I had something hung, and I kept thinking, okay, well, it'll just go down later. So that night, still didn't go down. Monday, I'm drinking. I'm thinking, okay, it's going to go down. You would think, I just keep thinking, this is kind of silly. I just have something lodged in my throat. So on Tuesday, when the water started gurgling when I was drinking it, I thought, yeah, maybe I should ask somebody that I know. So Ricky Bass is my primary care provider and my good friend, and he said, I'll see you tomorrow morning in clinic. Well, James Morris, this is James. How many of y'all know Dr. Morris? Okay, James is one of my favorite, truly, doctors. He is also on my ACS cancer study. So I decided to email James that day and that afternoon. And I said, I may be seeing you tomorrow. I said, I got something lodged in my throat, and it's kind of gurgling now. And so, 2 minutes later, I get this email from James. He goes, when was the last time you ate something? I go, well, I haven't been able to eat anything since Sunday. He said, when was the last time you drank? And I said, a couple hours didn't go. He goes, I'm in a meeting. I'm calling down. We're doing an endoscopy tonight. And I go, oh, okay, And so James consented me. It was great. His nurse was great. And in the endoscopy procedure, they have to tell you, one of the consequences is death. James told me that. So the endoscopy happens. James comes back in. He goes, look, he said, whatever it was dropped when we put you under. And he said you had a small ring around in your throat. And he said, and we removed that, but everything looked fine. But he said they did an x-ray on me to make sure that I had not perforated my esophagus, because he said, after several days, you have a greater chance. He said, don't ever do this again. And so he goes, and on the x-ray, they discovered there's a nodule on your lung. And so he said, Connie, people in Louisiana this isn't that uncommon. He said, have you ever had an x-ray? I said, no, I haven't ever had an x-ray. And he goes, are you sure? And I go, I've never been in the hospital except when I've delivered. They don't do x-rays usually then. And so he said, well, you were supposed to see Ricky tomorrow. I'm going to send you in to see him. He said, it's probably nothing. So I went in and I saw Ricky's resident first. She was perfect. It was ask before you tell, because they weren't sure James had told me about the nodule. So she came in, do you know why you're here? We're doing all this checkup. And so Ricky came in and he said, I'm going to get an MRI done and a CAT scan done, sorry. And he said, whatever you do, don't Google it. And I thought, that ship has sailed. I Googled it last night. So I happened to be in a meeting at Weiss-Weiler. Gary Burton was in the meeting, and I was telling him about it, and he said, oh, no, we'll have the CAT scan done tomorrow morning, and I'll read it for you. So I went in Weiss-Weiler. I would highly recommend, if you have to have a CAT scan, Weiss-Weiler is the place to do it. They're wonderful. I go upstairs. Gary is trying to find Gary. He's trying to pull it up, and at first it wasn't there, and he said, well, it takes a few minutes. And he said, Connie, these nodules, he said, it's probably a shadow or something, and right at that time, he pulls it up, and he went, no, that's not a shadow. He said, who's your pulmonologist? And I said, I don't have a pulmonologist. And so he called Bob Holliday, who's one of my second favorite physicians now. And Bob said, does she smoke? I've never smoked. I don't have a family history. He said, I'll see her in clinic on Wednesday. He was at a different clinic. And so Gary said, with the utmost care, it's going to be fine, Connie, no matter what it is, we're going to take care of it. I went back to my office and sobbed. And then on Monday morning, and it's the only time this has happened, and I will not throw University Health under the bus, but in my electronic record, my radiology report came up. And so I was able to open it up and look at it, and the last sentence said, nodule highly suspicious for cancer. And so I thought, I had gone through the weekend thinking everything was good, life is good, and I just went, great. So when I went to see Bob, Bob had a different opinion. He said, look, Connie, he said, here's your risk factors, here's what we know. He said, I don't see a lot of calcification on the nodule, but he said, you're just not at high risk for this. I don't want you to get stressed out about it. He explained to me, he said, we can do a PET scan. He said, you're going to find one of three things. One, it's going to show no activity. Two, it's going to show a lot of activity, and then I'm going to recommend you have surgery, because the nodule is not in a place that they could go through my throat to do a biopsy. And so he said the third option is it's going to be a kind of a hit or miss. There's a little bit of activity. I can't tell anything. He said, do you want to have the PET scan done? I said, I'll have the PET scan done. Had the PET scan done. Option 3. Couldn't really tell anything. So Bob said, look, we're going to have another CAT scan done I had one done a month later. It went from 1.5 to 1.6, or I may be screwing the numbers up, but that involved 15 and 16. Let's put it that way. So anyway, what Bob did not know is this is my brother-in-law. Ryan, his son, used to be a med student here. He's now a resident. But my brother-in-law has been a radiologist for 30-something years. He lives in Texarkana. He's married to my sister, my oldest sister. And so after the PET scan and the second CAT scan, my brother-in-law said, do you want me to look at this? I said, sure, it's fine. So, my sister kind of insisted. I thought, I'm really comfortable with the decision we've made. We're just watching it. So my brother-in-law calls me and he said, honestly, if you were my wife, what I would tell you is I would have a biopsy done. So he calls his friend who's an interventional radiologist. The interventional radiologist says, okay, before I see her though, she needs to have a surgeon, because if I find something, we're going to have to send her to surgery. So they hooked me up with the surgeon. surgeon looks at the stuff. The first thing he does when he walks in is he said, well, he said, I think I would remove it. Then he looked at it again, and he goes, well, let's go outside and look at the PET scan, look at the CAT scan. He said, you know, Connie, he said, from all I can see, I'm fine with us watching it. He said, Bob Holliday's going to do another CAT scan in 3 months. You know, he said, let me give you a piece of advice. He says, as a surgeon, I want to take everything out. He said, a radiologist wants to biopsy it. You know, he said, your pulmonologist is kind of taking the right road. And what convinced me not to have surgery was, he said, I'm going to have to cut open your rib cage. And he said, 6 months down the road, you're still going to be in pain. I thought, oh, we're watching it. But the reason I wanted to relay that story to you, so this December, I will have my 4th or 5th CAT scan. It will be 3 years out. 2 years is pretty good. It hasn't grown any. We're just watching it. But every step of the way, every single one of those people talked to me in a way that I understood and gave me options that I understood. And so for me, that's my personal story about telling you, about talking so that your patients understand what their options are. You know, it was always left up to me what my option was, and I always clearly understood it. And trust me, getting on the internet and Googling nodules on your lung is not helpful, because you come up with a lot of scary things. And so with that, oh, by the way, those are my 2 sons there. That is the end of this discussion, so I will take any questions if anybody has any. Okay, so y'all have a good day.